Hello, and welcome to tonight's Taking Care of You, Managing Side Effects Resulting from Treatment for Anal Cancer. I want to take this opportunity to welcome all of our viewers as well as our panelists to tonight's event. This is our first online event for the anal cancer community, and we hope it's the first of many. For those of you who are new to the foundation, I would like to take a brief moment to give you an overview of who we are. The foundation was established in 2010 after the Almada siblings lost their mom to anal cancer. When she was diagnosed and going through treatment, there was no foundation dedicated to the cause, no medical society working for a cure, and no support services for those who are experiencing a diagnosis. The Almadas are fixers and knew that something had to happen, so they created the foundation 5 years ago this summer. Since its inception, the foundation has provided seed funding for the first medical society for anal cancer, which is the International Anal Neoplasia Society. And here is the link. These links will also be available in the comment section of the video. They've also worked hard to advocate for gender-neutral vaccination and have created such things as HPV Action and the Noman is an Island campaign. Noman is an Island is our big awareness event for gender-neutral vaccination and seeks to also bring attention to the fact that HPV causes 6 different cancers in men and women. This summer, this is our 3rd year doing the No Man campaign, and we are in the middle of the event series. We have a rowing event coming up in July. So I suggest that if you haven't seen any of our No Man event information, you take a chance to visit that. We have also worked hard to create novel educational materials for the anal cancer community, including our fact sheets, events like tonight, and also support services like our peer-to-peer support program. You can see here. Tonight's event was created out of necessity. Our community needs information and deserves to have their experiences understood, acknowledged, and discussed. Our panel consists of thrivers and professionals who will discuss how to manage side effects resulting from treatment for anal cancer. Once our panelists have finished their discussions, we will open the floor to questions via the Q&A function on the Google Plus page, or you can email them to us at our email address, which is analcancerfoundation@gmail.com. And if you're having any difficulties with technology during our event, please feel free to call us. We have our program associate, Laura, by the phone, and here's our US phone number if you need to call. It's also available on our website. And after the event, we will have a survey available for people to fill out to respond about their feelings and how everything went, and also get feedback on what you'd like to hear from more of in the future. And that is available here at our SurveyMonkey. We would also like to note that anything that you hear during this event, before you decide to attempt any management that we're talking about, you discuss with your doctor, because what's right for one person is not necessarily always right for everyone. So thank you so much for attending, and thank you to our panelists. And we are going to hear from our first thriver, Connie.
Hi, my name is Connie, and I decided to just talk a little bit about kind of my history and my whole journey through this. I don't really even remember how long it had been that I noticed blood in my stool, maybe up to a year, but it was gradually getting worse, and I did some research on the internet, so I knew that cancer was a possibility, but I just assumed that it was hemorrhoids. When I finally decided to talk to my doctor about it at a checkup in October of 2013, I was only 49 and I had never had a colonoscopy, but she sent me to get one. And I remember waking up after the procedure and the nurse handed me some pictures that they took during the procedure. And I thought to myself, wow, these just look like tumors that I saw on the internet. So the doctor took a couple of biopsies, and then I just had to wait for the results. 2 days later, I turned on my phone when I left work to find that I had missed a bunch of phone calls from the medical offices. And so even before I talked to anyone, I had a pretty good idea what that meant. It was late on a Friday afternoon, so I scrambled to call them all back as soon as I could, and then I learned my diagnosis was squamous cell carcinoma. So I spent the whole weekend doing research. It was a 3-day weekend, so I had an extra day to worry about everything before I could see any of the doctors. And I tried not to be too scared. I only shared the news with my husband at first because we didn't want to worry everybody needlessly until we had more information. So over the next 3 weeks, I went through a whirlwind of appointments with a long list of providers, the medical oncologist, the radiation oncologist. I went to the chemo room and met the nurses, had my PET scan and CT scan, got my PICC line, and so finally, after all the tests, they decided that I was stage 2 T3 for the size of the tumor, about 5 centimeters, but N0 and M0. So I was very fortunate that they caught my cancer early. And the doctors all agreed that they would treat it with radiation and chemo, but no surgery. And they gave me an 85% chance that the treatment would be successful. So their recommendation seemed like the way to go for my treatment. And so I started my treatment early in November and through December in 2013 with 30 radiation treatments and 2 rounds of chemo, including mitomycin and 5-FU. And the information from the oncologist said some patients may experience a long list of side effects, and especially with the first round, I had pretty much all of them. I had the mouth sores. I lost probably about half of my hair, which I ended up having my husband shave off so I wouldn't have handfuls of hair in the shower and on my pillow in the morning. I had bad nausea, and within 24 hours, I couldn't keep saltines and water down after the chemo started, and my white blood cell counts dropped to nothing. The medical oncologist prescribed anti-anxiety medication for me, which was helpful. I didn't like taking it during the day because even though I was off work and didn't have anything to do, I didn't want to feel that groggy. So I took it at night to help me sleep. I was waking up a lot during the middle of the night and was just out of control worrying about everything under the sun, from paying my bills to would my loved ones get the flu and die. That was all over the news at the time that the flu epidemic was really bad. I worried about if something would happen to my husband or my daughter who's away in college. And so the medication helped me to sleep a little bit better at night. They medicated me for the second round of chemo with some anti-nausea medication. It would have been great if they had suggested that the first round of chemo, but they didn't. So my side effects were much less on the second round of chemo based on me telling them what I went through with the first round. So I was also fortunate that I could take off work during my treatment and for an additional month afterwards while I healed. And so I decided I was ready to go back to work when I could wear pants comfortably again. But I was still having a lot of urgent bowel issues, and so I learned to be prepared for any kind of an emergency like that. So I packed my purse with anti-diarrhea medication, with extra underwear and lots of panty liners, and a package of baby wipes for emergencies. I have to plan enough time before I leave the house that I know I won't need to use the bathroom while I'm driving somewhere. And for a few months when I got to work, the first thing I would have to do is run in from the parking lot to use the bathroom. But over time, that has gotten a lot better. My radiation oncologist also prescribed some medication for me that helps to slow down my bowel movements, and also suggested just adding some fiber to my diet, but not too much, and definitely making sure I get enough water so I don't go kind of in the opposite direction. I still have to take some of the anti-diarrheal medication occasionally, but I gradually am using that less and less. And so the urgent bowel issues aren't gone entirely, but it's getting better, and paying attention to my diet is helping a lot too. I'm working with a dietitian to learn about anti-inflammatory diets, and have actually tried an elimination diet to test certain foods for sensitivities. So what I'm learning is as long as I avoid spicy, fatty, and very sugary foods, I'm better off than if I eat those things. So my doctors are still currently the radiation oncologist and the surgeon who I see every 6 months, but alternating, so I see one doctor every 3 months. The medical oncologist said he didn't need to follow up with me once my blood counts were back to normal. And then the radiation oncologist actually referred me to see a GYN oncologist as well to help with the side effects from the radiation to my vaginal area. And he has prescribed an estrogen cream to help counteract the effects of that stenosis. And then after reading about pelvic physical therapy on the Anal Cancer Foundation website, I discussed that with my doctors and got a referral to see a pelvic physical therapist. And she's focused on not just the area where I had cancer, but she said she's going to treat my whole body. And the radiation effects on my legs and my hips have been affecting my balance and my energy level, my mobility and my strength, and my time of inactivity when I was under treatment, I think have contributed to all of that too. So she's teaching me a lot of exercises to work on those things and strengthen my pelvic floor muscles, and is teaching me how to use the dilators effectively to help with those side effects. So between eating a cleaner diet and getting more exercise, I am slowly starting to feel better. Again, it's been about 1.5 years. So it's been a long journey, but it definitely is better. And my husband reminds me of that when I'm having a down day. He says, look how far you've come since your treatment. So I continue to talk to my doctors about all the side effects and ask them for their help and their advice on getting better. And what I want all the cancer patients, and especially anal cancer patients, to know is that we're not alone out there. There is a lot of help, especially through this foundation. I am so glad that I found this website when I was doing my research. And that's my story.
Great. Thank you so much, Connie, for sharing your experience. I really appreciate it. Next, we're going to hear from another thriver. We're going to hear from Tony. So Tony, welcome, and you have the floor.
Thank you. So my name's Tony, and I live in Los Angeles. And about 6 years ago, when I was 53, I had some episodes of rectal bleeding similar to Connie, and I went into my primary doctor right away, and for 2 years, he insisted that I had hemorrhoids. And symptoms got progressively worse, and eventually, with those symptoms getting worse, he referred me to a hemorrhoid clinic specialist at the healthcare organization I was going to at the time, which was Kaiser Permanente, and he immediately, that doctor immediately knew that they weren't hemorrhoids, but that I had a tumor. And the primary doctor had also done like 5 anal exams and anoscopies over that 2-year period. So in retrospect, one of the things that concerns me is that primary care doctors and in general don't have a good understanding of, or not aware of maybe anal cancer, or don't look at it right away. And I think it's an area that thrivers in particular can try to be proactive in trying to improve care in terms of education and awareness. I am a gay man and as in a high risk group, and yet, you know, I had never heard really of anal cancer. Heard of HIV, but never anal cancer or HPV. So there's obviously a great amount of awareness and education that needs to be done, I think, in that area. But so 2 years in, I did finally get diagnosed, and I was diagnosed with stage 3B anal cancer. And you know, when I looked at the literature, the cure rate, survival rate certainly wasn't as good as stage 2 or stage 1, and I think part of that had to do with the fact that there was a 2-year delay in diagnosis. But I did get excellent care at Kaiser. They implemented what they call the NIGRO treatment, I believe it is, and that's a combination of radiation and chemo. and that was a little over 4 years ago, and I've been in remission ever since. And so I've been very happy with that. So moving on to like some of the side effects, there are short-term side effects, I think, and long-term side effects. Similar to Connie, I had short-term side effects during the treatment, mouth sores, which were severe and lasted several weeks, I believe, due to the chemo. And then, you know, in the anal area where I had the majority of the treatment, I don't know, I would call them anal burns or you know, the burning of that area due to the radiation, and that, you know, created severe episodes of bowel movements and things for a period of about a month, and then overall, you know, a period of probably 2 months after the treatment of pretty significant fatigue and weakness. But all of those short-term side effects did dissipate. I did return to work and have been, you know, relatively healthy since. So I'm sort of grateful to the doctors that treated me. In terms of long-term side effects, I'm 4 years post-treatment now, and I think some of the things Connie mentioned are similar to what I have. Is some bladder and bowel movement frequency and issues with frequency and urgency, and I too have been, you know, very happy that there is an HPV and Anal Cancer Foundation, because when I was first diagnosed, it was really sort of at the time that the foundation was just getting started, and I had the traditional resources of the American Cancer Society and things, but they didn't really hone in on the sorts of issues that I was having, at least in my view. And HPV Anal Cancer Foundation has been invaluable to me in terms of referrals for the bladder and bowel movement issues to a pelvic floor physical therapist, which I'm currently seeing, and he's made a huge impact in terms of helping me strengthen my muscles, making suggestions about, you know, how to deal with pain and things like that. So I'm grateful for that, and I think it's really an important resource. I think an additional area is ongoing skin sensitivity in the anal area for me, and I think the key there is that's something everybody, I think, reacts differently to radiation, but for me, just knowing how to deal with it, it's not a terrible thing, but it's, you know, I get irritation and pain sometimes for, you know, with like excessive wiping and things like that, and just some tips that I got from my current oncologist that I'm working with in terms of using Curel moisturizer and also Aquaphor ointment has been invaluable. So these are like very specific tips, but they're really important to me on a day-to-day basis. Another long-term issue is anxiety, and I think that's really important because there's anxiety associated with every aspect of this, from, you know, the diagnosis to the routine scans and getting the test results. And to me, managing anxiety helps not only with dealing with pain, because pain is, I think, accelerated or made worse by the way of anxiety. And I found that the best treatment for that is mindfulness. And I've read some books by John Kabat-Zinn, Coming to Our Senses, and just focusing on the present and not worrying so much about the past or the future has made a big difference for me. So that's one thing that I think is important. So overall, I mean, that's sort of a very brief brief overview of my experience, the initial diagnosis, some side effects long-term and short-term, and again, thanking the foundation for actually the other thing is hooking me up to the peer-to-peer support program, which is, you know, really invaluable, and be able to talk to others who are going through the same thing and share experiences. So hopefully that helps. That's it.
Great, thank you so much, Tony. That was wonderful. Thank you for sharing your experience and providing the tips that you have found helpful throughout the way. Thank you. Next, we're going to hear from Noreen, who's our third Thriver speaker. And let's hear what Noreen has to say. Thank you, Noreen.
Hi, my name is Noreen, and I'm 57 years old. I live in San Francisco. I have 4 kids. I was diagnosed 4 years ago in 2011, January, I think, of 2011. And right away, the doctor said he wanted me to have surgery. Well, I didn't even question it. I was, yes, get me surgery, take it out. So I started, once I recovered from that, then I started on, the same protocol that the others did with radiation and chemo. Though when I did the chemo in the 3rd week and then the 6th week, it was in the hospital. I was too afraid to not have it in the hospital, so I stayed in there. The first time that I had the chemo was no problem really at all. I didn't get sick or anything. The second time was much harder because I was getting the radiation daily downstairs, but I also had a lot of pain going on as well. So what ended up, the way that things happened were it's pretty easy, except for the anxiety, like the others talked about. I had some severe anxiety attacks. Just going up to do the radiation, it's only a couple minutes, but it was the whole mindset, I think, that makes you anxious. So I had to have some anxiety medication, but other than that, the other physical symptoms weren't a problem up until about week 5, I guess 5, yeah. And then I got really, really severe burns, vaginal and anal burns. I wasn't prepared for the vaginal ones because my radiologist didn't even tell me anything, so that was really hard. I did not know. I should have thought, but I didn't know that that's what the effect was going to be as bad. I did have an insert that they put in during the radiation. I thought that was a vaginal protector. Nobody told me anything, but it was really to aim it in the correct position to make sure that the radiation got there correctly. By the end of the time, I was not really able to use that without much pain. So I get through all of everything, and towards the last probably 3 weeks to a month, the burns were so severe, bowel movements were incredibly painful. Now, let me preface that to say I was taking pain medications, and I was taking a lot of them because I felt I really needed them, which of course was the worst thing I could do for going to the bathroom then, because you get constipated. So I do recommend you definitely take your stool softener. I guess I wasn't taking it right because it became a big problem for me. And what I did get was I went to my gynecologist, who was a woman. Both the others were men. And she gave me a salve that was, I can't remember the second thing, but it was like a lidocaine. And so I could use that, which helped somewhat. Otherwise, they don't want you to put a lot on because you're going to be radiated. So, yeah, so I did that, and that helped some. I think, so during the time, I did also get the mouth sores, so they gave me liquid Vicodin along with the morphine. Well, that became a problem for me. I'm actually an alcoholic and an addict in recovery, and I ended up getting addicted to these. It was too much for me, so if anyone deals with that or is in recovery, I would suggest you have people to talk to and you discuss it with your doctor first. I ended up relapsing after 11 years, but I now have a year and a half back, so I feel good about that, but didn't need to go through that pain. So the salve is really good. The other thing I would recommend is a woman told me about the Vermont Country Store. They have this underwear that is, you put it on and it feels like nothing. And which you kind of want to have something on, like the others were talking about with accidents possibly happening. You don't want to go with nothing. So that was really great, the Vermont Country Store. The other thing I used later on is like a donut pillow. It's a little bit tough at first, but I definitely had that. I didn't mention actually in the beginning that the reason that I found out what I had is the symptoms I had were anal bleeding and also really thin stools and felt like something was in there. So I went and got the colonoscopy. So I wanted to mention that. So my focus today is about the sexual aspect of this treatment, what it did to me. So it ended up causing vaginal stenosis for me, which is a shrink of the vagina. And I didn't know anything about that, it shrinks you. And so, I hear that and I didn't know what to do. Having sex was extremely painful. Plus, I was going through menopause, so that didn't help either. But it was really bad because you have this stigma you feel from the anal cancer. Then I felt completely, not feminine because I just couldn't, I didn't feel good. It didn't feel good. I was really worried about that with my marriage, though my husband was fantastic. He was, extremely patient. So I'm looking up things. The male doctors really didn't help me too much with that. And I found the Pelvic Health and Rehab Center in San Francisco. Oh, unbelievable. What a difference it made. I had no idea what I was getting into. I go there and they do an internal and external manipulation. And I'm like, do whatever, just help me. So I went for about 5 or 6 months, and unbelievable the difference that it made. They break away scar tissue is really what it is, on the outside as well. And plus, Casey, my therapist that I had, also did some yoga with me and show me different stretchings that I can do. This was extremely helpful. So also a suggestion as far as for sex, if there's pain, is coconut oil, I was told to use, because it's a natural thing that you can do instead of some of the other things that aren't so natural. Part of the reason that I found this place, though, looking online, is I belong to an anal cancer Yahoo group. I would definitely recommend joining that, because all it is thrivers on there that talk about all their experiences. There's so many, and it gets very graphic, which you want to have. You want to have the specifics so you feel comfortable asking the questions. So I would definitely look that up. The other definite that you want to do is to use a dilator. Men and women both. A dilator is basically a vibrator. They come in different sizes, that you build up to it. Nobody told me that. I didn't know that until I was finished. I couldn't get anything near me then. If you start in the beginning of your treatment to use the dilators, it helps to keep the vagina open. And I didn't know it could close, but apparently that can be an issue. So using the dilators up till the point, and then you'll have pain, so you might not want to use it then, but still 4 years out, I will continue to use that. If I'm not having sex, I will continue to use that to make sure that the vagina stays open, because it doesn't cure the stenosis, it just helps it. Anyhow, I think that covers it. And sorry about that. Also take Miralax. I still do that now daily. It's a laxative that's very mild. Let's see if there was anything else. I think I pretty much covered it, but coconut oil, dilators, the salve, underwear. Talk to your doctor about the what's happening with your sex organs, because it's really important. It was a major issue for me. But I'm doing very well now, and I feel good, and the Anal Cancer Foundation has been great for me, especially doing the peer-to-peer support. I would have loved to have had that. I did have the Yahoo group, but really having someone to talk to has been huge. So I'm really grateful, and I'm grateful that I'm cancer-free. Thank you.
Thank you so much, Noreen. We really appreciate you being so open and honest with your personal experiences. So thank you, Connie, Tony, and Noreen, for sharing your very personal experiences and providing people with tips and information. And I just want to remind everybody who's watching, make sure that you discuss any tips that you heard today with your medical team before attempting them on your own. Now we're going to move on to some of our professionals who work with the anal cancer community. And we're going to start with Allison, who's a PT, DPT. She received a bachelor's degree in exercise science from Sonoma State University and a clinical doctorate in physical therapy from the University of Southern California. She is a physical therapist specializing in pelvic floor dysfunction and treatment at the Pelvic Health and Rehabilitation Center in San Francisco. Allison is an active member of the International Pelvic Pain Society and is involved with community outreach and education in the Bay Area. Thank you so much, Allison.
Hi, I'm Allison, and like Cassie said, I am a pelvic floor physical therapist, and I work at the Pelvic Health and Rehab Center. And I actually work in Berkeley now. I used to work in San Francisco. I forgot to update that, but I actually work in our Berkeley office now. So I wanted to talk to you guys about some of the long-term side effects that, just like Noreen and Connie and everybody just mentioned, that people deal with after treatment for anal cancer. And I help people deal with a lot of things, but related to the pelvis. I'm going to talk about some things that aren't necessarily related to the pelvis, and feel free to ask questions later if you have any. But some of the issues that can arise after having chemoradiation or surgery for anal cancer are pain. It could be surgical pain. It could be pelvic or hip pain. Fatigue is a huge issue that I don't think gets enough press. Lymphedema, general just kind of weakness, neuropathy, deconditioning, like Connie I think had mentioned. And then pelvic floor dysfunction, stenosis like Noreen was talking about, incontinence, and sexual dysfunction are the major ones. And I think there's a huge role for physical therapy in the management of symptoms. Radiation, we always say, like, radiation's kind of the gift that keeps on giving. So once you have gone through radiation, it is important to continue to manage it lifelong, just like Noreen was saying. So I think physical therapy can help people get onto a management program and, you know, reverse maybe some of the progression. And then it's something that, you know, we can always help you to manage lifelong. So pain is something that people deal with, just general musculoskeletal pain, but also pelvic pain. And so things that we can help with there are just, you know, general manual therapy things. There's trigger points, which are kind of like knots in the muscles. Connective tissue issues, scar tissue is a big issue after we have radiation. And we can help with movement dysfunction that may be causing or maybe as a result of pain. So we can look at your posture. We can talk about where you're sitting, cushions to be sitting on, how you're walking, any range of motion impairments. Especially, I think Connie was saying that, you know, when you're getting chemotherapy and having radiation, it can be a time that you don't feel good and you're not probably active. And so it's a lot to come back from. To kind of regain strength and activity. Fatigue, like I said, is one of those things that I don't know, I sometimes think it gets brushed over or doesn't get enough press, but it is huge, and it can last for a certain amount of time, or it can last forever, and it's something that we have to manage. Chemotherapy can cause fatigue, and we call it cancer-related fatigue. And so physical therapy, just kind of general physical therapy, but they also have cancer physical therapists that can help with this more specifically, can help with planning, pacing, organizing your day, you know, and the physical activity around that. Exercise programs are important, so getting an aerobic, strengthening, stretching, balance program is really important. In 2009, there was a review that found that exercise was much more effective than not exercise in people that were recovering from all kinds of cancer. And then in 2004, there was a study from the Oncology Nursing Forum that found that moderate levels of exercise and physical activity were helped to relieve the cancer-related fatigue. So it's important, and it's not just something that you have to live with. It actually can be managed and improved, but it's kind of counterintuitive because it does take exercise and movement, and I strongly suggest having support during that time, because if you overdo it, then you're hosed the next day and it's kind of hard to get back from. So I strongly suggest finding someone to help you with that and doing that. Lymphedema is another issue, and that's not something that I deal with specifically. If you're having lymphedema, it's something that you want to talk to a certified lymph specialist about. But it happens especially after chemoradiation. Another thing that we kind of usually have to manage, but sometimes it's completely reversible. So if you're going to someone for lymphedema, things that they can do are, drain the lymph manually. They can help with skincare. They can get you fitted for compression garments. And so compression garments are, I printed out pictures, and they're not, we'll see how they look on here. So compression garments, so these are Jobst, which are my favorite, Jobst. And this is a female pair, and it's a whole pantyhose pair. So that's for people that are having all the way up to the pelvis lymphedema, which is common with anal cancer recovery because we're having radiation to the pelvis. So this is a whole pantyhose line, and they have these for men too. This just happens to be a woman. They also have, let me see if I can get this, thigh high. They have all kinds, but the thigh high and the pantyhose type are the type that are going to be most common for people that are dealing with anal cancer recovery. So this is just a male leg, but that's the thigh high version. And they range from 8 to 12 millimeters of mercury, which is, it's, firm but not super firm, to 50 millimeters of mercury, which is hard to get on. So you definitely, I would suggest talking to your doctor about this, and possibly a physical therapist, someone who knows what they're talking about, because you don't want to just go to CVS and buy it. You want to maybe get fitted for it, and make sure you've got the right pressure. But very effective, can be very, very effective. Exercise actually helps with lymphedema as well, and it's a thing that a lot of people have to maintain, but like I said, sometimes it is completely reversible. General musculoskeletal concerns that I deal with all the time are people that say, I feel weaker, and they usually are, because like I said, some people aren't getting out and moving as much as they want to or can because they don't feel good during chemoradiation. Neuropathy is an issue, especially with chemotherapy, so having neuropathic pain or decreased sensation is a huge issue around the anal sphincter, and also in your feet, sometimes in your hands, sometimes in the eyes, but usually for this specifically it would be in the pelvic region, but it does not have to be limited to that. And so again, I strongly suggest getting in with a physical therapist who knows what they're doing, or a personal trainer who has maybe been recommended to you by a physical therapist or a doctor who has dealt with this patient population before, so that they can help you create the optimal program for you. And so pelvic floor dysfunction, which is more what I deal with, is hold on just a second, I'm going to move this. Okay, is any stenosis, so anal or vaginal stenosis, any incontinence, so gas, fecal, urinary incontinence. Urgency, frequency is another issue. Because they've radiated that tissue often, the muscles in the area are very irritated. So their way of telling you that they're irritated is often to give you pain, urgency, or frequency, with bowel or urinary urgency or frequency. And so things that we need to do to manage that: sexual dysfunction is another issue, and that kind of goes in with the anal and vaginal canal stenosis. So things that we can do to manage that are help you think of ways to plan your day, like I said before. Dilators are huge, so I brought some dilators. This is a dilator. This is just one type of dilator. There's many different types. This is from vaginismus.com. And so this is a handle. This is part of the dilator, and you can change the size. So I can take this off, and this is the smallest size, and this is usually where people start. And I recommend this, kind of like Noreen was saying, but I recommend this for anybody who comes into my office, to right away, as soon as they can tolerate it, start with anal dilator, so this would be probably this size, and vaginal dilation. Because often I'm seeing people that come out, they haven't been told about dilators, and they've got severe stenosis. So we want people to be using these dilators. And they're not, you know, anyone can tell you, I'm not going to sugarcoat it and say they're fun to use, but they're very, very important to use. So this is that. They go up to this size, which may or may not be appropriate for you, but they are graded and come in many different sizes. But anyway, this is what you would be using on probably a daily basis to start, and then we usually get you going to like 2 to 3 times a week, depending on what works for you. So that's a huge part of my practice. In my office, we're often doing manual therapy, kind of breaking down the scar tissue that we can that's been caused by any radiation. We are working on muscle control. So as you all may know, the muscles are affected by radiation, and once they are burned, they stay that way, but we can still gain some strength and control in the surrounding musculature that hasn't been affected. So we're looking at you know, endurance, strength, overall control, power, in order to stop any incontinence, urgency, frequency, because all of that plays a role. All of those muscles play a role in our bowel and bladder function. One thing I wanted to show you guys is, I'm going to try and screen share this really quick. Screen share. Can you? I don't know if you guys can see that, but can you see that, Cassie? No.
No, we can't see it.
Okay. Well, the vagina and the anus are really close together, so when we get them, when there's radiation, like Noreen was saying, a lot of people don't know this, but it's important that we recognize that the vagina can be affected with radiation to the pelvis. So again, we want to be looking at that. There's some pads that just came on the market called butterfly pads, and they actually like have these sticky things that stick inside the gluteal cleft or the butt crack, and they have a pad that goes right at the anus. So for people that are having just a little bit of leakage or like kind of mucosal leakage that's coming out, that has been a great product that I've been able to suggest to people, and they sell them at CVS, and they're meant to absorb what's coming out of the anus, so they're not urinary, they're not period pads, because those are not meant to absorb like fecal matter. So those have been one of my best things that I've been able to recommend lately. And anything else? So I think physical therapy is appropriate for most people that have gone through chemoradiation for anal cancer. Like Cassie had mentioned, please get clearance from a medical doctor before coming. But anybody who's post-surgical, post-radiation, having pain in the lower abdomen, groin, vagina, anus, genitalia, and any scarring, please come in. Bowel, bladder dysfunction, so incontinence, constipation, urgency, frequency, pain with bowel movements is a big thing. If you're having sexual dysfunction, if you're not able to have intercourse, if you're having pain with sexual intercourse, that's another time to come in. So that is my main stuff that I wanted to talk to you guys about. And if you need help finding a physical therapist, great websites are www.pelvicpain.org, and my company website is www.pelvicpainrehab.com, and we're there to help you. There's blogs on how to find physical therapists in your area, but we're there to help you locate one if possible. So that's it for me.
Great, thank you, Allison. And I also just want to let everyone know, Allison has contributed to our blog on our website, where she's provided links on how to find the pelvic floor physical therapist, the ones that she just discussed. So if you go to the analcancerfoundation.org website, locate our blogs, there's a 3-part series by Allison. So thank you very much, Allison, for that, and I hope people talk to their medical providers about the benefits of pelvic floor physical therapy. Next, we have Melanie. Melanie is an RD, is a registered dietitian nutritionist who currently works as an outpatient radiation oncology dietitian at Memorial Sloan Kettering Cancer Center. She counsels patients undergoing radiation on managing any symptoms that occur during and after treatment. Melanie attended the University of Connecticut, graduating with her Bachelor's of Science in Dietetics After graduation, Melanie began her career at Mount Sinai Hospital in New York City, working inpatient on the oncology unit, and then expanding to also covering the bone marrow and transplant unit. In 2009, she started working at Memorial Sloan Kettering Cancer Center in neurology and palliative care. She became a certified specialist in oncology nutrition in 2010, and then in 2011 moved to the outpatient position she currently holds. Thank you, Melanie. Here she is.
Okay, hi. So what I'm going to talk a little bit about today is managing your diet during and after treatment with radiation. So I'm sure a lot of you are familiar with the low-fat, low-fiber diet, which I typically recommend people start following about 2 to 3 weeks into treatment, especially with radiation. And the one thing I always make clear to patients is you don't have to follow, we don't usually recommend following a low-fat, low-fiber diet immediately. You should kind of wait a few weeks before you start developing symptoms, or else some people will develop constipation, which can be an issue. And then about 2 to 3 weeks after treatment is usually when we encourage people to start reintroducing foods into their diet that aren't necessarily consistent with the low-fat, low-fiber diet. So what I usually encourage patients to do is after about 2 weeks, when treatment's completed, I encourage them to start trying to reintroduce some easier to digest fibrous foods. So maybe adding some more, like some vegetables that have been cooked, adding in maybe some whole wheat breads, as long as there's no nuts or seeds in them. But I would wait a little bit longer to start those. But maybe trying some more raw fruits. And then as you progress, if you tolerate those, you can move on to more grains and beans and nuts, depending on how you're doing. The one thing I always tell people is to try to stick to only adding one new food every day or so, and see how you tolerate it before you move in, expand to adding more foods into your diet. Start with a small portion and then kind of go from there. And the other thing I always encourage people to keep in mind is that you might tolerate, let's say, half a cup of cooked broccoli with dinner, but if you had it with brown rice or maybe with beans, you might find that that's more of a problem. If you had a salad at lunch, you might find that you're having a lot of issues later in the day, or diarrhea, let's say, the next day. So you have to kind of keep your whole diet and your whole day in mind when trying to figure out what you tolerate and don't tolerate. I often encourage people to really keep a food log of what they're eating. And the other thing I try to encourage people is to remember that there's a lot of things that can really affect your gastrointestinal system. So it's not just necessarily what you eat that can cause gas, bloating, and diarrhea. It can be stress. It can be anxiety. You can have gas and diarrhea with increased physical activity, caffeine, high-fat foods, spicy foods. So those are also things to kind of keep in mind. It's not always necessarily just about the fiber. And the other thing I always try to make clear to patients is that it does take several hours for foods that you eat to basically be digested and for you to have symptoms. So a lot of times gas and bloating might happen pretty quickly after you eat something, but something like diarrhea could be from something you ate the day before, even a day and a half, depending on how fast your gastrointestinal system is, which varies. So that's something that I often kind of encourage people to keep in mind, because a lot of patients think, I ate this at lunch and then I immediately had diarrhea, and it usually isn't what you just ate. I encourage people to keep a food log, which I kind of mentioned earlier. So the food log, I encourage people to write down what they're eating, especially once you start reintroducing new foods to your diet, to write down what you ate, what you drank, maybe if you did any physical activity different than usual or anything was out of the ordinary. Write down how you're feeling symptom-wise, and writing down not just what you drank, what you drank, whether it's water or seltzer, whatever it might be, but also writing down, did you drink it with your meal? Did you drink it after your meal? Because drinking fluids with your meals can sometimes affect how quickly things are digested or emptied into the into the intestines. So that's always things that you can keep in mind, and then you can start to find patterns in what you tolerate or don't tolerate. Similar to what Connie was saying earlier about the elimination diet, you can start to kind of do that semi on your own not exactly what she's doing, but kind of seeing what exactly is a problem for you and what's not, trying to find the patterns in what you're eating. When it comes to trying some over-the-counter things, obviously speak to your doctor, but sometimes Metamucil is something that people find helpful. A lot of people think it's just for, let's say, lowering your cholesterol or for constipation, but it actually can help just regulate bowel movements in general. So what I tell people to try to do, some people have success with it, starting off with a dose a day and then increasing it after about 3 to 5 days. You can maybe start a second dose. But you want to make sure you're getting plenty of fluids. A big mistake with adding fiber to your diet, there's 2 big mistakes patients make, that most people make, I should say, not just patients, is that they'll try to add more fiber into their diet, but they'll do it too quickly, so which can cause these large bowel movements. And if you're not drinking enough fluid in addition to taking all that extra fiber, you'll end up with these hard, dry bowel movements that are going to be especially difficult or painful to pass. And that, as I said, it can happen to anybody that makes diet changes like that. So the key is really starting it slowly, adding new foods in and adding more fiber in and making sure you're getting plenty of fluids. Another good thing that I sometimes suggest for people, that it's very common for people to develop a lactose intolerance during treatment. So I encourage trying lactose-free products like obviously there's a lot of options out there now with soy products and rice milk and almond milk, but also there's Lactaid milk. Lactaid also has a lot of products like cottage cheese and ice cream and yogurts, and they also have pills. So if you're out with family and you have a slice of pizza or you want a little bit of ice cream, you can usually keep the Lactaid pills. I encourage people you can also get the CVS brand of lactase. And that usually helps with managing some of the symptoms that can kind of be a long-term issue, because the lactose intolerance is very common among adults, and it really, especially after the radiation, it's a lot more common. It's a lot more of an issue for people. People are much more sensitive to dairy products. And then the other thing that I sometimes suggest is talking to your doctor about perhaps looking into a probiotic. Some are better than others, and some are more specific in what types of bacteria they have that can help with certain things. Like, I believe Culturelle is one that has specifically supposed to be beneficial for lactose intolerance. But that's, as I said, talking to your doctor about that. Seeing a dietitian is obviously is going to give you a lot more than me. Seeing somebody that can really sit down and go through the food log with you, really sit down and discuss what exactly in your diet seems to be the problem. They can find a lot more of patterns and issues and give a lot more insight into that. And I always encourage people to find either if you're looking for a dietitian, I would speak to your doctor first, see if there's somebody that their office works with. See if there's somebody that they recommend. If there's nobody that your doctor would recommend, I encourage people to go to www.eatright.org/find-an-expert. And you can actually search by what expertise you're looking for. You can search by put in your area code and find somebody nearby to you. The key when you're looking for a professional to talk to your diet about is looking for a registered or certified dietitian/nutritionist. To become a dietitian, you have to get your bachelor's or your master's in nutrition, but also you have to go through an internship. You need 1,000 hours of experience. Then you have to sit for an exam, and you have to keep up with your education every 5 years. It's much easier to just become a nutritionist just by getting a bachelor's or whatever in nutrition. But becoming a dietitian is a lot harder, and that's usually who I encourage. We have a lot more training in regards to looking at lab work, medications, and more medical experience. So, and like I said, so it's www.eatright.org. You should be able to find it on there, but it's /find-an-expert. Thank you.
Thank you so much. And I just want to let everyone know that the links that are being discussed, we're going to make those available to everyone as well. We're going to try and put them in the comment section as much as possible during the event. but we will also send those out to everyone after the event as well. And if you have any specific questions about any of the links, feel free to email us at the analcancerfoundation@gmail.com email address. Thank you, Melanie. Next, we're going to listen to Eric tell us about HBO therapy. Eric is a retired Navy diving and explosive ordnance disposal officer who came to Duke Dive Medicine from the Duke Hospital Surgical/Trauma ICU. Prior to completing his nursing education in 2002, he was an instructor at the College of Oceaneering in Los Angeles, where he taught a variety of subjects, including hyperbaric chamber operation, diving medicine, and emergency medical technology. Eric's fieldwork in commercial diving has included offshore oil pipeline inspection, harbor maintenance, and underwater inspection and non-destructive testing of commercial shipping. He holds U.S. Navy certifications as a surface-supplied and rebreather diving supervisor and hyperbaric chamber supervisor. He is also a Duke Code team educator and a member of the Duke Hospital Code Blue Committee. So now we're going to hear from Eric, and thank you, Eric, for speaking.
Thanks, Cassie. First of all, if you're wondering what a diver could possibly be doing in a conversation like this, what I want to talk to you about specifically is the 10 to 20% of people who receive radiation therapy who suffer from late effects of radiation, and I want to differentiate that from the radiation burns that I think Noreen and Tony talked about, and many who are watching probably suffer from. Those are the initial effects of the radiation. When we're talking about late effects of radiation, we're talking about things that happen anywhere from 6 months on out to many, many years following radiation therapy. Typically, it's seen, and I have to be honest with you, I don't know what the typical dose of radiation for anal cancer treatment is, but usually seen somewhere above about 60 or 70 gray, 6,000 or 7,000 centigrade. That's usually how I measure the radiation dose. And I've heard a number of side effects that are certainly unpleasant. And when we're looking at the late effects of radiation, we're talking about the more serious end of that spectrum. That can include radiation cystitis, radiation proctitis, radiation vaginitis, non-healing wounds, non-healing ulcers in the area, fissures and fistulas. We've seen rectourethral fistulas, rectovaginal fistulas. Urethrovaginal fistulas, we've seen all three of them connected. And so that's kind of what I want to address right now. Like I said, anywhere from 10 to 20% of the population who receives receives radiation therapy suffers from these late effects of radiation. At the Duke Hyperbaric Center, that's about 80% of our population, or 80% of our patient population. We treat other things like diabetic ulcers, compromised skin flaps and grafts, the odd diabetic ulcer, the odd diver who has the bends from the coast. But for most of our patients are late effects of radiation. And I heard the stenosis mentioned several times. That plays into it. Another thing that radiation can cause is a reduction in the density of capillaries in the tissue, so that reduces the circulation in the irradiated area. And it can cause scarring, like many of you have probably experienced, but can also result in non-healing wounds. And if a person suffers from a wound in an irradiated area, it can be very, very difficult to heal. Hyperbaric oxygen therapy is often used as an adjunct to help heal that. The way it works is a person is placed inside of a chamber, and if you've Googled hyperbaric oxygen therapy, you may have seen one of these. They vary in size and shape. Ours at Duke is what's called a multi-place chamber. That means we can fit more than one person inside, and the patients breathe oxygen through a head tent that looks an awful lot like a space helmet. Other hyperbaric chambers are monoplace chambers. Those are the ones that look like Snow White's coffin that most often you see on the internet. They're pressurized with 100% oxygen. The physiology and physics is the same no matter which one you use, and so is the effect. But the end result is a patient is pressurized inside this chamber and given oxygen under pressures greater than ambient pressure, and basically the effect of that is we were able to dissolve oxygen into the blood plasma. Oxygen is normally carried on the hemoglobin on the red blood cells, but if you don't have enough capillaries in a particular area, you don't have enough red blood cells and therefore not enough oxygen getting to a particular area. And we see that it's a thing that's common to people with radiation injury, to people with diabetes. The net effect is essentially the same. So we dissolve the oxygen into the plasma by increasing the pressure that the patient breathes, and the physics behind that is the same as the physics that keeps the carbonation dissolved inside your favorite carbonated beverage, whatever that happens to be. So when you pop the cap on that carbonated beverage, you notice all those nice bubbles that come out there. Those bubbles are actually the gas that was dissolved inside the beverage underneath the cap. And so we basically turn our patients into giant oxygen beers, for lack of a better comparison. We give them the oxygen under pressure, and inside the lungs is where the gas fluid interface in the body is. You've got two thin layers of cells in between the gas in the lungs and the blood plasma. We dissolve oxygen through those layers into the blood plasma. It can then get to places where it wouldn't be able to get otherwise, and it can only happen inside of a hyperbaric chamber. Once it hits that chronically hypoxic tissue, it sets the body's normal healing mechanism into motion, and it can help heal wounds. I think probably and I have to admit, I haven't seen a whole lot of anal cancer patients. Most of our patients that we see are either prostate cancer or uterine cancer or cervical cancer. But any kind of pelvic radiation can produce these long-term symptoms. Radiation cystitis typically presents as painful urination, urinary urgency, and blood in the urine, or hematuria. A lot of our patients end up, the way they find out they have this is they end up in the emergency room retaining urine, and they have to get catheterized and figure out there are big blood clots in their bladders. It can also present as radiation proctitis or vaginitis in the form of non-healing wounds, rectal fissures, vaginal fissures, and fistulas. So if you're experiencing anything like that, you may be a candidate for hyperbaric oxygen therapy. And one interesting thing about hyperbaric oxygen is that the devices that are used to administer it have to be FDA approved. The indications do not have to be FDA approved. And so there's an organization called the Undersea and Hyperbaric Medical Society. I actually emailed Cassie a link to this, along with links to our website. The UHMS is a scientific body that looks at all the research out there about hyperbaric oxygen and meets annually and says, yeah, there's enough evidence to say that it works for X but not Y. A good example is late effective radiation is one of the UHMS approved indications. If you do an internet search for hyperbaric oxygen, often you'll see people treating autism and other things like that for which there's little scientific evidence. And so I would encourage you to seek out a chamber that's approved by the UHMS, or that at least treats the UHMS indications. If you're experiencing early effects of radiation, you'll probably find a hyperbaric chamber to treat you, but it may not do you any good. And so there are a lot of hospital-affiliated hyperbaric facilities out there. Most of them practice evidence-based medicine, are the ones that you're going to want to be talking to if you want to consult for hyperbaric therapy. I put a link to our website up, and or I actually sent it to Cassie, and if you look, hopefully she'll link it. And if you're looking for a hyperbaric chamber in your area, but you're not sure where one is, feel free to call us or email us. We can help you find one. But chances are, if you Google hyperbaric oxygen therapy and place your city name in the search engine, you'll find a hospital that has a chamber near you. Most of them are affiliated with wound care clinics, but the good hospital-affiliated ones will also treat late effects of radiation. The side effects of hyperbaric oxygen are pretty minimal. If you've ever scuba dove or flown in an airplane or driven through the mountains, you know that your ears pop when that happens. That effect is much more pronounced in a hyperbaric chamber because the pressure change is much greater. At Duke, typically we treat our patients at a depth equivalent of about 33 feet, which is twice atmospheric pressure. Some chambers go as deep as 45 or 48 feet. So patients can suffer from barotrauma or ear injury, but that's relatively minor and relatively rare. We have all kinds of ways we can teach people to help clear their ears. Some of the contraindications, really it depends on the facility. There are very few people that we can't treat at Duke. We see some fairly sick patients. Chambers will typically turn down people. The monoplace chambers are reluctant to treat people with pulmonary blebs or bulla. That's open areas of the lung, either congenital or from lung cancer or tuberculosis or something like that. Some chemotherapeutic agents can be harmful when used in conjunction with hyperbarics, like bleomycin. If somebody's on bleomycin, we will not treat them until the treatment cycle is over. So I would encourage you, if you're suffering from some of these more severe side effects like non-healing wounds, radiation cystitis, blood in the urine, non-healing wounds down in the vaginal area or rectal area, and you're more than about 6 months out from your radiation therapy, you may benefit from hyperbaric oxygen therapy. It's not a magic bullet, but we do find, like with our radiation cystitis patients, about 50% of them experience at least some relief. I'm sorry, about 50% experience complete relief, and about 80% experience at least some relief. And so I realize it's a kind of a niche field, but I'm open to questions if anybody has any. That's about all I have.
Great, thank you so much, Eric. I think for a lot of us that's new information, so I really appreciate that. We're opening up the Q&A section right now, so feel free, those of you who are viewing on the Google Plus page, to submit your questions to us. And I'm also getting some questions in via the email. So actually our first question is for Allison. So I'm going to click the screen over to Allison and talk to her for a second. Allison, does it matter if your pelvic floor physical therapist has worked with anal cancer patients before?
You know, I would say it would be preferable that they had worked with an anal cancer population before. However, if they haven't and they are familiar with working vaginally and or rectally, both would be preferable, then I think that they would be appropriate. You know, most physical therapists go through training in their doctoral programs about cancer treatment, so they know like the what do you call it, like the rules of treating somebody who has been radiated. So not necessary, but preferable.
Great, thank you. Our next question is for Eric. And Eric, we have somebody who has been through kind of the regimen that you were discussing after treatment, and wants to know what the maintenance protocol would be if, you know, after doing it for, you know, multiple weeks for an hour every day, if there's any sort of maintenance plan that is typically used.
Oh, so you're talking maintenance plan for hyperbaric oxygen?
Yeah.
That's a really good question. I probably should have addressed that when I spoke initially. The soft tissue radiation injury can be very, very difficult to treat, and often we'll find that our patients will undergo up to 60 hyperbaric treatments. At our center, we offer treatments twice a day, so the patients can get the treatment series out of the way more quickly. The facilities that do once a day, and most do, you're looking at a pretty good sized time commitment, and it has to be done sort of in conjunction, one right after the other. You can't do two one week, one the next week. It's got to be on a very set schedule and very frequently. Usually we ask for 5 days a week, and we even offer it 6 days a week. So if 60 treatments mitigates the symptoms, but a person comes back later and has a recurrence of symptoms, often we'll give them a booster series of treatments, and it's kind of titrated to the individual need, so we can go 10, 20, 30, 40 treatments. So yeah, excellent question. There's not really a constant. The thing about Michael Jackson sleeping in the hyperbaric chamber is a myth. So too many treatments, anywhere above about 80 treatments, a person becomes at risk of cataracts. And so we don't treat people on a long-term basis in the hyperbaric chamber. We'll go for up to 60, let them go at 60, and then if they have a recurrence or if their symptoms are still there, we can bring them back, a few months later for a follow-up series. But excellent question. Thank you.
Thank you. That was great. Our next question is for Allison again. Allison, do compression garments help to cure / resolve the lymphedema, or are they just worn to manage the symptoms of swelling?
It totally depends on the level of edema that you're having and I guess severity, but they are usually there to manage. If cure is an option for you, and that would be something to talk to your physical therapist or doctor about, they are there to cure you. But for the most part, I'd say for the majority of people that have to deal with lymphedema, compression garments are a management.
Great, thank you. And this next question, I don't know if Allison, you could answer this. Maybe a thriver who used one of these creams, but would Radioflex prescription cream be preferable to Aquaphor for healing? I don't know if anybody used that or knows about that. Anybody? Okay. So that's a question that we got from our email, so I will look into that and let people know what I find later. Our next question is for Noreen. And Noreen, could you speak more about what you did in pelvic rehab? The person who wrote the question is 4 years out, stage 3B, with Mets to inguinal nodes and aggressive radiation. Has used various creams, dilators, and has sex often and still has pain with intercourse. So kind of how did you navigate that?
Well, when I went to the rehab place, as I mentioned before, they do internal and external manipulation. And like Allison was talking about, you have the scar tissue. So that was the most important, I think, for me, for the stenosis. Is that what you're asking? You're asking what?
Just more about what you did, what your regimen has been in the pelvic therapy.
Okay, yeah. So she had advised me right away to continue using the dilators. I didn't know how long you really needed to use them. Basically, kind of forever. If I continue to have problems, there's no pain with sex now. As I mentioned also, we did some yoga, which did stretching. Also, one of the things that she did was, I have C-section scars. She manipulated that scar tissue, being everything is all connected. And, it helped almost right away.
Great. Thank you.
Did that answer the question, or was there more?
That's it, I think. Thank you.
Okay.
Nancy, can I jump in on that one too? I'm sorry. I know I'm jumping a question, but yeah. I wonder if the questioner has had an exam and actually had a speculum put in there and looked for some sort of wound in there. And I'm not sure what aggressive radiation is. I can see the question, but it's a possibility that the woman has a wound inside the vaginal canal that could be causing the pain. If so, I think that's one person who I would probably refer to a hyperbaric consult. But I think it's worthwhile getting that looked at.
Great.
Also, you mentioned on there the speculum. He happened to mention that. One of the things I wanted to say is that my OBGYN uses a child's one, a child speculum.
Great. Thank you, both of you. Thank you, Eric and Noreen, for that. Okay, I have a question that came in via email, and the person is stating, I had eye problems, meaning my prescription changed after treatment, ending late November. How long will it take to go back to normal after hyperbaric oxygen therapy? So this is for you, Eric.
Yeah, that's another good question. That's a relatively common side effect of hyperbaric therapy. It's called myopic shift. So if you're nearsighted, you get more nearsighted. If you're farsighted, your vision actually gets better. About 99% of the population goes back to baseline within 3 or 4 months. There's a product out called the AdLens Emergency. I'll write it down. This isn't a product plug, but we give them away at our Hyperbaric Center. I'll see if I'll hold it up. It's searchable. I'm writing it down right now. They go about. Can you all see that?
Yes.
Okay. So the AdLens Emergency eyeglasses. You can get them on the internet. They're about $20 each. The lenses are adjustable. You turn little knobs on the sides, and you can adjust them as your eyes go back to baseline. So that's an awesome product.
Great. Thank you. Our next question is for Melanie. What about animal protein and eggs? I have found that since I had cancer, my need for protein to mitigate fatigue is much higher.
Protein intake during and after treatment is really important because a lot of people will lose muscle mass during radiation, even if they don't lose a lot of weight. So the good thing about chicken and eggs and fish and most meats are typically well tolerated during and after treatment. That's not something that, unless they're very high in fat or they're very tough, some people do find that they're difficult to digest, but otherwise they're usually really well tolerated. So if you find that you need more, that's pretty typical, pretty normal, depending on where you are after completing treatment, but it's definitely something that should be well tolerated.
Excellent. Thank you. Our next question is through the Google Plus Q&A, and the question is, how far from the radiation center can/will the muscles be affected? So I think I'm going to let Allison start us off with that question.
Okay, the question was, could you repeat that, Cassie?
The question is, how far from the radiation center can/will the muscles be affected?
Okay. There's no like hard and fast rule, but it can be, so because the radiation is not exact and radiation is like a wave and can be kind of anywhere in the air, it can affect, I would say, from ribs to knees theoretically, but often it's limited to pelvic, abdominal, upper thigh, buttock area. So that's usually how far out I've seen it affect people, but you know, theoretically it can go from ribs to knees, basically, on either side.
I'd like to add something to that. One of the things that I have found that I also read on the Yahoo groups is my teeth. I've had a few teeth that have chipped or broken, 3 of them actually in the past 4 years. And I didn't think anything of it, except that on the Yahoo groups there were many people that were talking about that it could be a side effect from that.
Thank you. Thank you, Noreen.
I'd like to add, Cassie, something as well. I know they talked about the weight loss and all of that, and I lost about 30 pounds while I was in treatment, and not all of that was fat. I could tell that I lost muscle everywhere. So that's definitely something that the physical therapist is addressing with me. The radiation effects maybe are not throughout my body, but I have definitely lost muscle mass everywhere in my arms, throughout my legs, and throughout my body.
Thank you, Connie. Our next question is for Melanie again. This is from somebody who is going through treatment. What should I do if I can't keep anything down? What about if I have 0 appetite?
Did the person ask this via email or live?
Email.
Oh, I was going to ask, why can't they keep food down? So if they don't really have an appetite, unfortunately there's not a solution for that. I mean, there are medications that can help with appetite, but we're not finding them to be worth the side effects, and they don't make you gain actual good weight. You usually just gain fluid weight. So when patients are having a loss of appetite, we really encourage just eating, kind of treating food like medicine and eating based on a schedule, trying to find foods that do work for you, versus really looking at it the way that we normally look at food, which is eating what you enjoy. It's really going to be a matter of just eating every 2 hours, set a schedule, set a reminder, and just get something in that works for you. Focusing on things that have protein, things that are well tolerated, like I said, low fiber foods. And then there is, for some people, they find that taking like a supplement or making a shake is the easiest way. So that is something that I do address with patients. If you find that it's harder for you to prepare a snack or a meal, making a shake or a smoothie that's high in calories and protein typically works for people. Some people choose just having Ensures or Boosts, but they also have, like, now they've made Ensure Clear. So if the patient's having nausea, Ensure Clear is a juice drink that has protein and more calories than juices, so some people do better with that versus a smoothie or a shake. But if they're making their own, they could use lactose-free milk, banana, peanut butter, and ice or whatever else they'd like to add, and that would usually be well tolerated bowel-wise, and also, you know, so it's going to be low fiber but also have protein and calories. So I hope that answers the question.
Yeah, that was very thorough. Thank you. Our next question came in via email again, and this is for Eric. And I think you may have kind of touched on this a little bit, but how long will the benefits of HBO therapy last? Will they wear off at some point?
It kind of depends on the individual response. Typically, we say that so the end result of hyperbaric oxygen therapy, or the ideal end result, is that we grow the patient's new capillaries in the area, so then the tissue can be supplied with oxygen. It never goes back to the original capillary supply that a person had pre-radiation. But we usually say once you have them, they're yours to keep. However, that said, we do see some people come back with wounds again. So it's highly individual. I would say most of the people we treat don't come back. But a couple of patients that come immediately to mind, we've seen more than once. So it's hard to say. But probably the more profound the wound, the harder the time we have healing it, the more likely they are to have long-term effects. But usually, once the effects are there, they're there to stay.
Right, that's really good to know, especially when people are investing a lot of time into this therapy. It's good to know that they have long-lasting results. Yeah. Thank you. Okay, so our next question, and maybe some of our thrivers can speak about this if they've experienced this, and maybe Allison knows something about this as well, or Melanie. The question is, I completed treatment almost 3 years ago, and I have a belly that keeps getting bigger and bigger, although I only weigh 121 pounds. Do you think this is the result of the chemo, and is there anything that I can do about it? Does anybody want to answer this? Any of our presenters? Does anybody have any experience with this or knowledge about this? Allison, is this something that you've seen or experienced with people?
They said they have a belly that's getting bigger and bigger?
Yeah, and they wanted to know if this is a result of chemo and if there's anything that can be done about it, or if you have any even suggestions as far as, you know, going back to their oncologist.
I would go back to your oncologist.
Okay. Great. Thank you. Okay. Our next question is for Allison. I am a 7-year thriver. What steps would I take if my vaginal opening has healed shut?
Okay, so that is usually a surgical issue when it's completely stenosed closed. So what usually you can go with a gynecologist, can do the surgery, and they just kind of, you know, it's not a very invasive surgery, but they do use an instrument to open the vaginal canal again, and immediately, you know, maybe like 14 days or whenever the surgeon says that you can start doing it, immediately after you want to get in with a physical therapist and get on a dialer program. So it is like something that is a surgical issue to start, and I have seen that several times. But after that, we got to manage it right away, and it's a lifelong management.
Great. Thank you. Our next question is on the Google Plus Q&A, and the question is for Eric, and it's, can hyperbaric oxygen therapy be helpful for radiation-induced neuropathy in the feet and legs?
That's another highly individual question. That'd probably be one for a hyperbaric physician to evaluate in person. So usually not, but usually it's more the wound type of issues that we see. Radiation. We've treated some radiation optic neuropathy with relatively little success. So I would say if there's a question, by all means seek out your closest hyperbaric physician and ask, but not typically, no.
Thank you. Okay. Our next question is from our email, and it is, what is mucosal leakage? And how, it's a two-part question, and how high up can scarring from radiation go?
So mucosal leakage is just what it sounds like. So it is a mucus that typically comes out of the rectum or anus. In the rectal canal and anal canal, we have mucus in there to help move stool along, so it's not, dry. It's helpful to have a little bit of like lubrication to move it along. And so sometimes people will find that they just get like sort of a brown mucus that leaks the anus. And so that's what I was talking about when I said mucosal leakage. And the other question was, how far up can the radiation?
How far up can the scarring from radiation go?
It can go up the entire canal. So like I said before with radiation, because it is in the atmosphere almost, when they give it to you, it can, like Noreen was saying, maybe it affected her teeth. It can go pretty far up. So as far as the vaginal canal, it can go up all the way to the cervix. As far as the anal rectal canal, it can go up, potentially into like the large intestine a little bit. So, that's not a hard and fast answer, but that is a possibility.
Thank you. Our next question is from our email account again, and I'm going to direct this towards our thrivers. I am 1 year out of treatment and still have 5 to 6 urgent bowel movements. I think a day. There's some of this question that might be missing. And they use Consul and Imodium. Is there any other products that you have used that have worked for you, and does this get better in your experience?
I could speak to it to start. Or, I would say what really, as far as the urgency and frequency goes, I think the physical therapy referral and development of the muscles and the exercises, I started that very late, and I think if you haven't done that already, that to me would make a big difference. No specific medication, but the physical therapy referral would be a big help in that regard.
Great. Does anybody else want to add anything to that? Thank you, Tony.
I can, Cassie. The prescription medication that my radiation oncologist prescribed is called sulfasalazine. It's a sulfur drug, so it's probably not a good thing for just everybody to take. I know some people are sensitive to that kind of medication, but the goal behind that was to just slow down the process of the bowel movements. And then I know Melanie suggested the fiber with Metamucil as well, that adding that fiber back into my diet as I can tolerate more fiber has really helped to slow things down. So I've reduced from having probably 10 bowel movements a day down to where I have maybe 4 to 6. So it's definitely improved over time. It just takes a lot of work with your diet and with the fiber, and I think the medication makes a big difference. The times that I've gone off the medication just to test if I'm better, I usually need to go back on it. So it's definitely something to talk to the doctors about and see if there's something better than just taking Imodium all the time to slow things down.
Thank you, Connie. Melanie, do you have any experience with patients using, and I hope I'm saying this right, it's Konsyl, Konsyl, or Imodium?
With Imodium, I am familiar with that. I haven't heard of Konsyl. I'm not sure if it goes by another name that maybe I've seen.
Okay.
But it is common for people to use Imodium during treatment and afterwards. The other one is called, I think loperamide is another one that some people will take. So that's something else that they could talk to the doctor about. I believe loperamide is a little bit stronger because I know you need a prescription for it. And some studies are showing that it's really beneficial with managing that, as well as I did see a couple research studies about something called sucralfate. So that's another option, but definitely talking to the doctor. I haven't heard of the one that they had mentioned. I heard of the Imodium, but.
Okay, thank you. Our next question is through the Google Plus Q&A, and it is, I'm having difficulty returning to long distance running. I can run short distances, albeit painfully. However, my leg muscles, glutes, and hamstrings aren't getting any better or stronger. Is this radiation fibrosis? If so, how can I help this? I'm going to direct this towards Allison.
It doesn't sound like it's radiation fibrosis. Radiation fibrosis, you can feel it. So the muscles feel like different. They don't feel plush and like soft. They feel really hard. It sounds like it may be like a muscle fatigue type thing, and muscles can show you fatigue with pain. So I would check with a physical therapist for sure with this. Check with your doctor and then check with a physical therapist who knows about cancer rehab. Doesn't have to be a pelvic physical therapist, but just a physical therapist that knows about cancer rehab.
Great, thank you. We actually have a comment from the from our email about a question that we just addressed, and this is, I think, relating to the bowel movement question. And somebody said, I found acupuncture extremely helpful in terms of having normal and less frequent bowel movements. So that's something also to ask your doctor about that others in the community have found helpful. Okay, our next question is from our email as well, and it is, I am terrified of having a colonoscopy in a few weeks, as I fear that it will irritate the lining of my gut, which is functioning normally now. Do you have any suggestions? Are some laxatives less irritating than others? Allison or Melanie, do you know anything about this as far as laxatives being less irritating for in preparation of a colonoscopy?
I don't.
What I was going to suggest, I know that I believe it was Noreen that mentioned Miralax, which is a more gentle laxative, but I'm not sure if they would want something that gentle with the colonoscopy coming up. They usually kind of want things to be pretty cleaned out, so they might not want the patient to use something like that. Usually they give people Go Lightly. And I mean, some people find that I don't know if they've had experience with Seneca and that's what they're worried about. Seneca can be really, some people can get a lot of cramping and pain with it. So sometimes like a Colaze and Miralax, if they're starting early enough before the colonoscopy, they might find that they're going to have good kind of cleaning with that. But typically they would recommend like a Go Lightly. I don't know if Noreen would have more experience with that as well.
Okay,
That's what I would say also. I would just say the Go Lightly also, having had two. The first one was pretty brutal, the Senecot, I think she said. But the Go Lightly made a huge difference in my reaction to it. And the doctor, I was concerned about that, so I asked the doctor, and they gave the lighter version.
Great. Thank you, Noreen. So our next question I'm going to direct towards our thrivers in the group. It is, I am 2 days away from the end of my 6 weeks of treatment. Will things, sorry about that, will things get worse when it ends? Or is this last week the worst? Tell me what's ahead. I'm worried about getting back to work.
I found personally that it got worse at first. I finished the beginning of May, and for the month of May, it seemed worse, and then it gradually got better. So right after, I think you're getting the residuals of the burns. I did.
I would agree with
Great.
I would definitely agree with that. It definitely accumulated a little bit following the treatment as well. And so I know the doctors had told me that I might be able to work through the first couple of weeks of treatment, but with the cumulative effects, I would want to be off work through the at least the last 3 weeks, and then for a few weeks afterwards. So I was able to take the whole month after the treatment, and then I was feeling pretty ready to go back to work by that time.
Great, thank you. And Tony?
Similar experience. I was. It definitely got worse, particularly the anal burning and bowel movement issues. Several weeks past treatment, it definitely gets better, and it took about a month before I felt well enough to go back to work, fatigue-wise, as well as the bowel movement pain.
Thank you. Okay, our next question is for Melanie. I was septic during treatment and had strong antibiotics. I am the only person I know who gained weight with treatment and after. Could this be a gut flora problem, and how do I get back to normal? I don't know if you can address that. Tips.
No, that's actually a really great question. It could be a gut flora question, could be a gut flora issue. Unfortunately, there is research coming out about that, but there's not enough to say that to recommend a probiotic specific to that or what. What I would suggest doing is really trying to add some healthy bacteria into, healthy probiotics through foods into the diet as long as you're allowed to, so yogurts and things along those lines, and then talking to your doctor about taking a probiotic would be a good option. But it definitely is something that more recently some research is coming out saying that that's definitely a possibility for why some people gain weight, is their gut microbiome. So that could be part of it. But it should kind of improve with time with being on a healthy diet and having, as I said, natural probiotics in your diet and maybe taking an extra supplement.
Great, thank you. We have another running related question. I'm a runner as well and finding it hard to return to the continual pace. I wondered if it's lung issues. Does anyone have any lung issues, or Allison, do you know of anything that could be related to lung issues?
I don't know of specifically lung issues that they may be having, but I have seen like cardiovascular implications after having chemotherapy and or radiation, and I would strongly suggest you see your primary care physician and get like a stress test so that we can look at like lung and heart function.
Thank you.
I also, I've actually, one of my colleagues went to, I believe it was the American Institute for Cancer Research conference. I believe that's where she heard it, but they are coming out with new studies finding that a person's ability to take in deep breaths or their VO2 max, whatever it might be, actually can be very much so affected by chemotherapy. So that's something to kind of keep in mind as well.
Thank you. Our next question, I think maybe Allison, you could help us answer this. I'm starting to experience some degree of anal and rectal prolapse. What can I do to mitigate, or is it reversible? You heard of it.
Yeah, it depends. Often, whatever has occurred is kind of what will stay, but it depends on how much we can get the muscles to work in our favor. So I would definitely suggest seeing a physical therapist and working on some strengthening, because sometimes after the radiation and especially the radiation, the muscles like stop kind of being active, and then the vaginal wall and the rectal wall start to prolapse, and because they're weakened because the muscles aren't there to support them. And so any muscle strengthening that we can do would be helpful, but also sometimes we have to wear a pessary, which is like something that you can wear inside the vagina that kind of props everything up. It's removable. Surgical would be the last option, but that is if a prolapse gets to be like a very high grade, and surgery is kind of the last option.
Great, thank you. Okay, it looks like we're getting a couple of comments, people adding to what's been said. Let's see, someone just said, I just had a colonoscopy, and they prepped, I'm sorry, some of these are coming in fast, with milk of magnesia and Dulcolax laxative, very easy, and no Gatorade. Also, as far as the colonoscopies are concerned, it's really important for people to listen to their physicians as far as prep is concerned for colonoscopies and what laxatives are necessary. So make sure that when you're preparing for your colonoscopy, you consult your physician who will be performing it as far as what you should do. Let's see, are there any other questions? Again, feel free to use the Q&A app and email us as well. Let's see what I have here. Okay, this one's for Allison. I live in a small town with no physical therapist and cannot afford to see a physical therapist. Are there any exercises you can recommend that I can safely do at home to help alleviate my side effects?
That is a hard question to answer because I don't know your situation and I don't know what your side effects are. So I don't know if that can come in, or you're welcome to call my office and schedule a phone consult, and they're free, and you can always ask questions that way.
Right.
And the website was pelvicpainrehab.com, and the phone number's on there.
Okay. Do you know of any online videos that are reliable, or any sort of pamphlets that people can refer to as well, or is it just kind of the sites that you've recommended already that people should really be looking into?
I hesitate to recommend too much because it's so specific, and I don't want to be strengthening if that's not appropriate, because it can actually make things worse. There are websites that I could recommend, and they're actually not for cancer specifically. Like one website that I love, it's called it's like mutusystem.com. It's MUTU system.com, and it's for new moms. But it has this great progression of core and pelvic floor exercises. So if that was appropriate for somebody, I would totally I would not hesitate to recommend that. But I always have to kind of evaluate before I give those recommendations.
Thank you. I think that definitely makes sense. As far as everything that you hear today, also like we've said before, make sure that you discuss with your medical team before attempting. Let's see. Trying to see if there's any other questions. Don't think we have any other questions right now. I'm going to just let us pause for a couple seconds and see if anything else comes in. And I want to take this opportunity again to thank all of our panelists who have taken the time out of their schedule today to speak with us and answer our questions, and our thrivers who've been really open and honest with their experiences. So thank you to all of you. for participating tonight. And I know that the information that you've shared is really invaluable to so many in the community. So thank you for that. Again, some of the important links that have been discussed and websites, we're going to try to get that out to all of you as soon as possible, either putting them on our website, doing a follow-up blog, just so that you have all the resources in one location after this event. We are hoping to do more events like this in the future, so please fill out that SurveyMonkey that I mentioned before, talking about your experience tonight. Here's the link again, as well as you would like to see from our future events. This is really key when we're doing these events, is getting your feedback. We do have another question that just came in, and it is, I am 1 year out from treatment and still have a lot of blood in my stool. It is also in the toilet paper and on the toilet paper. Colonoscopy and endoscopy were fine. Is this normal? So I don't know if any of our thrivers want to share what they've experienced, or if Allison, you know anything about that.
I can share a little bit. What I've read and talked to my doctors about is, there may be multiple sources of that, so they definitely should talk to their doctor about it. Eric mentioned the fissures and things like that, and I've had problems with those too. Because the radiation damages the tissue so much, I think it does leave us prone to those kinds of injuries to the anus. So it's important to talk to her doctor or his doctor about what might be causing the bleeding. Again, that it seems like it is a normal post side effect, but definitely should be addressed with their doctor what the cause of that might be.
Thank you.
Yeah, especially a year out, if I can just tailgate on that, that would be considered more of a late effect of radiation. Sometimes when they go in there, they can see an active bleeder. Sometimes they can't, and sometimes it's just that if the tissue gets stressed, especially that irradiated tissue that's a little bit stenosed, the skin is delicate. If it gets stretched out a little bit, it can stretch, it can break whatever delicate blood vessels are in there and cause intermittent bleeding. Also, if the bleeding is significant, it can cause anemia, and so I'd definitely echo, go get evaluated by a physician. And again, that could be considered a late effect of radiation, so it might be worth looking into further.
Great, thank you. Okay, we have another question, and this one is for you, Melanie. How much is sugar in one's diet a factor in cancer?
So that's a really good question that I get a lot. The one thing I always tell people sugar does feed cancer cells, but it also feeds every other cell in your body. So the one thing I always kind of make clear to patients is that you can't stop making sugar for the rest of your cells. So even if you cut out sugar from your diet, you will get sugar from vegetables, because carbohydrates will get broken down into sugar. You will get sugar from grains like in beans and brown rice. The concerning issue when it comes to sugar and increasing your risk for cancer is when you're overdoing the sugar, which usually leads to weight gain, especially in the abdomen, which can kind of alter your hormones, and then increase your risk for developing cancer that way. And the other thing that I always tell patients is that when you're eating high sugar foods, they tend to be processed, they tend to be less nutrient dense, and that's usually where the issue with kind of sugar feeding cancer comes from, as opposed to naturally occurring sugars. So we're never really worried about sugars coming from fruits, vegetables, whole grains. We're more so worried about it when it's a big part of your diet and it's coming from processed foods and juices and things along those lines.
Great, thank you. Okay, I have a question from someone, again about a colonoscopy. Is there a possibility of the scope irritating the anal passage again during a colonoscopy? I don't know if any of our thrivers have experienced that at all. Allison, I don't know if your patients, once they've had a colonoscopy, that's something they've...
What was the question again?
The question is there a possibility of a scope irritating the anal passage during a colonoscopy?
I could speak to that a little bit. I think, yes, you do have some, it's a little bit uncomfortable, first of all, because you're already irritated somewhat from the emptying of the bowels. Also, I know when I've had the rectal exams, yes, I can be sore for a while, but it usually doesn't last long.
Thank you. Does anybody else have anything to add to that question? Any sort of experience with that?
I mean, I've had a colonoscopy, post-treatment, and I didn't really experience any real problems. So I think that's good.
Great, that is good. Thanks, Tony. Okay, I think that we're gonna wrap things up now. We have a couple of comments that came in that I'd like to share with everyone. One is, as a 25-year-plus survivor of anal cancer and have had chemo, radiation, this event is mind-blowingly awesome. Yay! So informative and hopeful. The Thriver stories are amazing. All echo mine completely. Provider shares, incredibly helpful, and only wish you were all around 25 years ago, but so glad you are here now. Thank you, thank you, thank you. So that's from one person, and we have another comment. Thank you all. I got issues answered even my docs have not been able to address. So I think that these really speak to the importance of these types of events and the importance of having our panelists here to share their experiences and professional knowledge about anal cancer, and all of you who've asked these really great questions during our Q&A. So to wrap everything up, I would like to thank everyone who's viewing this right now for listening and sharing and questioning what we have presented. And I would like to thank our professional panelists for sharing their expertise and years of knowledge and education with us all. Thank you. And our Thriver panelists for sharing really personal details about their experience with anal cancer. It's not always easy to share these personal details, so thank you from the bottom of my heart and everybody who's viewing for sharing that with us tonight. I just want to recap a couple of things. I'm going to plug again the survey. Take a few seconds. There's only 9 questions, so it shouldn't take that long. So if you could fill that out tonight or tomorrow, that would be great. Also, if you continue to have any questions for us, please email us. And also, if you haven't already, email us so that you can sign up for our mailing list so you can easily find out about events like this in the future. And also, you heard from our Thrivers tonight about the peer-to-peer support program. So please participate. We're really working to grow this community. It's a wonderful resource, and I personally love getting to know everybody who is in the program. So again, thank you so much to everyone who participated. A round of applause to our panelists. And this is going to be available on our Google Plus page and YouTube page indefinitely. So please share it with other professionals, other Thrivers who would like to learn more about anal cancer. Thank you all very much, and have a good evening.
Thanks, Cassie.
Thank you.
Thanks.
Bye. Thank you.